Now, the last main group of viruses we're going to talk about in the positive-stranded RNA virus family are the retroviruses. And what's interesting here about the retroviruses are that they don't use that mechanism of replication. They do everything completely different, okay? So these are positive-stranded RNA viruses that don't use a negative-stranded virus, RNA virus as a template, or RNA as a template. They use double-stranded DNA as a template. So the virus that we're going to clearly focus on are the retroviruses, specifically HIV. But I will point out there are other viruses in this group, most notably human T-cell leukemia virus, or HTLV. Exactly what the virus name suggests is what you're going to see in the patient, and you'll see it specifically in higher incidence in the Caribbean and Japan. Okay, those are some of the high incidence areas for HTLV. Okay, we're going to look a little bit at the structure of the HIV virion itself, because it's going to be important in a lot of the clinically relevant questions that they're going to ask you about this virus on step 1. So first, let's notice that the virus is enveloped, okay? And you can see again this lollipop stick that's in the envelope. What you need to pay attention to is that the GP120 part, the actual lollipop part of that, is the attachment protein that physically interacts with CD4 and the co-receptors. Okay, so that's important. Now, the stick part of that glycoprotein is the transmembrane GP41 protein, and that is a fusion protein for HIV. All right, so we have attachment and we have fusion. Now we want to move in a little bit to the inside of the virus and the nucleocapsid. So here's your nucleocapsid. All right. What you're looking at inside of the nucleocapsid is that, again, there are actually 2 copies of the RNA. So this is actually diploid. It will also carry with it a couple of copies of reverse transcriptase. We'll take with it a protease that we're going to look at in a minute for the replication, and an integrase. Now, this capsid, the nucleocapsid, the capsid protein here, is P24. Now, P24 is going to be very important when we start talking about HIV diagnosis, because antibodies to P24 are one of the first antibodies that you can detect during infection with HIV. So keep that in mind and kind of want to have an idea of where that came from when we start looking at the immune response to HIV. Now, the next couple of tables are simply looking at some of the genes that HIV has and what their functions are. And the first table are showing you mostly a lot of structural proteins. So you have the GAG, the POL, and the ENV genes. The envelope proteins are, of course, those glycoproteins that we talked about, GP120 and GP41, used for attachment. The GAG genes are a lot of structural proteins and your capsid proteins, nucleocapsid proteins. So here where you have P24, P17, and the P7, P9 for the nucleocapsid. The POL is short for polymerase. So think of all your enzymes here, the reverse transcriptase, the integrase, which allows the viral copy of the RNA, so the double-stranded DNA made from the viral RNA, to integrate into the host cell. And then you have the viral-specific protease that is responsible for cleaving the polyprotein made by the virus. Now, some of the regulatory genes that HIV has, you can see, are the long terminal repeats, okay, and that is used for integration of the viral genome as well as gene expression. There are some other regulatory proteins. So you have your TAT protein, which is a transactivation protein, transactivator of transcription. You have your REV protein, which is a regulatory protein that helps you to up-regulate the transport of both spliced and unspliced transcripts into the cytoplasm. But in addition to the long terminal repeats, what's probably most important here is NEF. NEF is a regulatory protein, used to be called negative factor, okay? This is how it got its name. Nef is actually responsible for virulence of the virus, okay? Now what I'm going to tell you is how you can use Nef in a clinically relevant scenario and how you might see it show up on the boards. You have a patient that comes to you. They are diagnosed with HIV. They're HIV positive by all intents and purposes. They are, let's say, too poor to be able to afford all of the multi-drug therapies that we use to treat HIV. And now it's 20, 30 years later, okay, and they still haven't developed AIDS, and they're not on antiretroviral therapy. So what is one of the explanations for that is they have an infection with a Nef-deleted HIV virus. So Nef is responsible for virulence, and you can have long, long, long infections with HIV if the Nef is deleted. It's actually one of the things that they're looking for as far as a vaccine candidate for HIV. Now, what are some of the functions of Nef? Nef actually can decrease CD4 expression and class 1 MHC expression on the host cell, can also manipulate the immune response, but again, that last point under there is required for progression to full-blown AIDS. So Nef is extremely important. Okay, we're going to look at the viral replication, and we're going to animate this a little bit just so the slide isn't so busy for you. But just like all other viral infections, HIV needs to get into the cell by attachment. What is it going to attach to? You definitely need to know specifics here. It's going to use GP120. It's going to attach to CD4, and it's going to use what? The co-receptors. Now, early on in the infection, the co-receptor that's used is not CXCR4, it's actually CCR5. CXCR4 is the co-receptor that it shifts to later in the infection. All right, so we're going to attach, and then we're going to dump the virion into the host cell, and we're going to start getting uncoating, and we're going to begin now to replicate this very strange virus. All right, so now we have released the RNA. You can see you've got reverse transcriptase here, and what that's going to do is take this positive strand of RNA and convert it into double-stranded DNA. Okay, that's the first part of replication. Now what happens is we're going to, with the integrase that the virus makes, is we are going to integrate that viral DNA into the genome. Okay? Now, every time you get transcription from that area of the genome, you're going to make virus. Some of the RNAs that you make are going to be cleaved, some are going to be uncleaved. The uncleaved mRNAs are going to be used as viral genome, whereas the cleaved RNAs are going to be used for protein production. So, uncleaved, we have the genome, again, positive stranded RNA. The cleaved, we're going to start getting protein synthesis. Again, both structural and unstructural proteins, so we're going to start making more integrase. We're going to start making more reverse transcriptase, okay? And then we're going to start to be able to assemble the virus, okay? So now we're starting to get viral assembly, okay? So even though, again, it's a positive stranded RNA virus, it has a completely different mechanism of replication. The last thing that the virus is going to do, of course, is it's going to leave the host cell, but it's going to take with it that cell membrane as its envelope. And what are these little lollipops? These are the glycoproteins that HIV is going to use for attachment. GP120, as again, the actual lollipop, and the stick is GP41. Okay, let's look now, start looking at some of the specifics of disease with HIV. We know that the reservoir for HIV are predominantly humans, where the macrophages truly serve as the reservoir, as do T helper cells, okay? And we know that HIV is transmitted through close sexual contact, can be by direct contamination of dirty needles, for example, and possibly, even as frightening as this is, transfusions, and also can cause vertical transmission. Okay, the disease begins like a lot of other viral diseases, okay? So we're going to initiate this infection. The asymptomatic infection that you see listed first here might also present as just kind of mononucleosis-like symptoms, okay? So it could be asymptomatic. You could have mononucleosis-like symptoms. It can then progress to persistent generalized lymphadenopathy, again, similar to what you see with mono. Then the disease is really following the decline of your CD4 T cells, all right? And as soon as your T cells dip below 200, you have hit what we call clinically as full-blown AIDS. Now, what I want to talk about are the CCR5 mutations. Because CCR5 is the initial co-receptor that's used for HIV infection, there are individuals that have a homozygous mutation in CCR5. Those that have a homozygous mutation in CCR5 are immune to HIV because the receptor, the co-receptor, is required, and because CCR5 is on the first cell types that are infected with HIV, if you don't have that co-receptor, you are immune to infection with HIV. Okay? Next, if you have a heterozygous mutation in CCR5, you're not immune, so it's not as good as immune, but even without antiretroviral drugs, your disease is on an extremely slow course, all right, because you don't have as much CCR5 as somebody that has two good copies, okay? All right, again, the course of the disease is going to follow the decline of CD4 T cells. And again, as I mentioned earlier, that was clinically relevant about NEF deletions. Long-term survivors, even without heart therapy, can happen when there is a deletion in the NEF protein. Now, what we're going to look at and what is super clinically relevant for step one are all of the opportunistic infections, okay? Now, we have talked about some of these already. Some of these you're going to see in the chapter on fungi and parasites, okay? But we're going to start to see some diseases that we might call indicator diseases, that something's not quite right because they're opportunistic type diseases. Bacillary angiomatosis, okay? Recurrent yeast infections with Candida are all very, very common early on in HIV. Your constitutional symptoms of fever and diarrhea that's persistent, also very indicative of some of the early stages of the symptomatic period for HIV. Some of the other things that you can see, again, in the symptomatic stage, your hairy oral leukoplakia, which we said was from EBV, idiopathic thrombocytopenic purpura, listeriosis, PID, are some of the other what we call indicator diseases, indicator symptoms that you're going to see with HIV. And also what's very common to get is peripheral neuropathy from the HIV infection. Now, the next group of organisms we're going to look at are associated with patients that are clinically defined as AIDS patients. Okay, so their T cell count typically we're talking is below 200. So, encephalopathy that's related to the HIV virus itself is associated with full-blown AIDS. Recurrent pneumonias, which we will talk about in the chapter on fungi from Pneumocystis jirovecii, leading cause of death. A lot of other fungal infections, a lot of those that are systemic, like coccidioides and histoplasma, for example. Cryptococcus, which you'll see in the fungus chapter, is the leading cause of meningitis in AIDS patients, and of course, pneumocystis pneumonia. Carcinomas, usually related back to a virus that can no longer be suppressed by the immune system because the immune system just isn't there. So invasive cervical cancer, Kaposi sarcoma, all examples of viruses that we've talked about that can cause cancer that when the T cells, when the immune system is down, are unable to keep those viruses kind of in check. Mostly what you're going to see in AIDS patients, as far as really bad viral diseases, are the herpes viruses. Remember, with the herpes viruses, they're the gift that keep on giving. So once you get them, they're never, ever going to go away. So now you have a CMV infection. You have VZV at some point that goes latent. What's going to happen? As soon as your immune system goes away, those viruses kind of come out to play and cause significant and serious disease. Additionally, other viral infections that are important here, and we've talked about PML already from the JC virus, is what you're going to see again in AIDS. And then a wasting syndrome that's due to infection with the HIV virus itself. Now I'm going to give you a money question here for the wasting syndrome due to HIV. One of the questions they love to ask, because they can tie it in with immunology, is which cytokine is responsible directly for the wasting syndrome in HIV. So I'll give you a second to think. It's actually tumor necrosis factor alpha. So the wasting syndrome that you see in HIV is actually due to the expression of TNF alpha. Moving on with some of the infections that are associated with AIDS, the parasitic infections that are going to be covered in the last chapter of this video, including Cryptosporidium and Isospora as a cause of chronic persistent diarrhea in AIDS patients, and then Toxoplasma, which is the leading cause of focal CNS disease in AIDS patients. Bacterial infections we've discussed already, tuberculosis as well as some of the atypical mycobacterial infections, and then recurrent sepsis due to salmonella infections as well. Now, I want to look at with you in this table some of the different opportunistic infections and when it's recommended to begin prophylaxis for prevention. So, for example, pneumocystis jirovecii, you're going to begin prophylaxis for that when the T cell count dips below 200, okay? And we're just kind of moving down the list here. Toxo and histo, we're going to start prophylaxing when the T cell count hits below 100. And when the T cell count hits below 50, we're going to prophylax for the atypical mycobacteria, CMV, and Cryptococcus neoformans, okay? And it's more important right now to understand when you're going to start prophylaxis, because they're probably just going to ask you a question about that, and they're less likely to ask you when you're going to discontinue prophylaxis. That's more of a step 2 type question, okay? Now, laboratory analysis for HIV deals with a screening test and a confirmatory test, okay? Your screening test for HIV is an ELISA, typically looking for P24, okay? The confirmatory test, and they love to ask about this on boards because really it's the only way they can ask a clinically relevant question about a Western blot, right? So they love to throw that on there. So your screening test, you got to know, is an ELISA, and you have to know the confirmatory test is the Western blot, okay? Now, we can use PCR, and here's when we typically use PCR, to determine viral load, and when that's particularly important is when we have an infant born to an HIV-positive mother, okay? So in that case, you want to determine the viral load in the infant, you're going to do PCR. Very early marker of infection was that capsid protein, P24, okay? And again, antibodies to P24 come up relatively quickly in the infection as well. One of the best ways you're going to evaluate progression of the disease is to look at the ratio of CD4 to CD8 T cells. Okay? This is typically done with flow cytometry, and when we talk about the immunology section, we're really going to go into some detail on flow cytometry. We're going to look at some histograms and show you specifically how you would do this. But right now, keep in mind that your T cell ratio is approximately 2 to 1 in a healthy individual. And that means 2 of the CD4 to every 1 CD8. And that ratio is going to shift as the disease progresses, right? So that's a good way to mark the progression of HIV. Now, treatment for HIV, they're going to cover again more specifically in the pharmacology, but we're going to look at some of the different mechanisms, again, because they're targeting viral replication for the most part. Now, well, first of all, let's talk about HAART treatment. HAART treatment is what we're currently using to treat HIV, and it's a combination therapy. It has worked so well, if you can remember back when Magic Johnson first got diagnosed with HIV, he's on HAART therapy, and he's currently still doing pretty well, okay? And that was decades ago. So HAART therapy has really, really helped with HIV. And what HAART therapy attempts to do is we know that with RNA viruses in particular and reverse transcriptase, there's always a lot of mutations going on, and the virus can develop resistance fairly quickly to one drug. All right, so you put them on AZT, for example, and the virus develops resistance to AZT, and you don't know it until your patient is really sick, and it's very difficult at that point to control. So now we throw this cocktail of drugs at the virus, typically with 2 nucleoside analog drugs and a protease inhibitor, so that if the virus develops resistance to one of those drugs, you have 2 more in there, keeping it down, keeping it in check. All right? So you got to know a little bit about HAART therapy. Just to help you out a little bit, the reverse transcriptase inhibitors can be nucleoside or non-nucleoside analogs, and those usually end in -ine, whereas your protease inhibitors end in -inavir, okay? So that might help you remember which drugs are which. The newest class of HIV drugs are the class of fusion inhibitors, and we're trying not to use these very much unless there is widespread resistance. These are not just pills, so they're not taken orally. These are injectable drugs, and again, we're kind of holding out so we have an additional drug, and we're targeting a different area of viral replication. Okay? The CCR5 co-receptor antagonist is a great idea, okay, because it's going to hopefully not allow the virus to attach to that co-receptor. And remember, it needs the co-receptor to initiate that infection. We also have integrase inhibitors available now. Keeping in mind that the fusion inhibitors, the CCR5 antagonist, and the integrase inhibitors aren't going to be your first-line drugs of choice for HAART therapy. Okay? In that case, you've got your nucleoside analogs and your 1-protease inhibitor. If you start seeing resistance develop, then you're going to start toying around with some of those newer classes of drugs for the therapy. All right, as far as prevention of HIV, right now we really don't have much. Education is probably the best. We are really working hard on a vaccine, but there's none currently available. Okay, so this is probably going to be, eventually the vaccine, hopefully, is going to be the best mechanism of prevention, but again, currently there are none available. There are certainly some in clinical trials, though.